All right, good everybody. Good afternoon. My job over the next 10 minutes is to demonstrate to you why CHG is not a good dip or irrigant for primary IPP placement. These are my disclosures, grant research support, as well as a consultant and educational faculty for Chlorhexidine and Boston Scientific. So when CHG was introduced to prosthetic urology, it was really exciting. There was a potential for a solution that was an antimicrobial, an antifungal, and an antiviral. It had fair cost, and there was a lot of hope of making our operating room more streamlined. And in a lot of ways, we thought of Irrisept as maybe this golden type of solution that we might be able to incorporate into our practice. Well, let's just take a step back. We're not the first people to look at Irrisept. Orthopedic surgery has significantly looked at Irrisept, as well as many irrigation solutions, which we have adopted into prosthetic urology. And if you think about orthopedic surgeons, they're not using Irrisept and have not adopted it outright. And when you look at the data, there's no clear consensus on the best irrigation solution in the orthopedic literature. So why should we as prosthetic urologists go gung-ho on Irrisept? And let's look at the urology literature. We have literature that has looked at wound irrigations in prosthetic surgery. We know that wound irrigation solutions can reduce infection rates. And this is both in revision wound washouts, as well as in salvage washouts. And that can increase increase infection-free rates. But within prosthetic urology, we also have studies which have evaluated wound irrigations and demonstrated that they can be harmful. Intraoperative betadine irrigation was associated with a 9-fold increase in infection compared to antibiotics. So we have data within our own field which demonstrates to us that sometimes we need to be cautious about what solutions we use during surgery. We need to understand and recognize that penile prostheses are completely different than any other type of prosthetic device in the medical field. Our devices are nearly completely coated or impregnated with an antibiotic solution. There is no other device like that. Therefore, when we talk about the WHO recommendations, for example, those are on hips and wounds, but we need to think about whether our surface needs special attention different than other devices in the regular wound. We have data demonstrating that the impregnated and hydrophilic coatings are crucial. That's why we use them. And these are the fundamental properties which have helped us to reduce infection for the past 25 years. So when we think about a new or an ideal irrigation solution, it should not interfere with the innate protection that is provided by the impregnated antibiotic surface or the hydrophilic coating. This solution needs to be both compatible as well as safe. So this puts us in kind of in the middle. Boston Scientific and Coloplast, they're not going to exactly tell us how to dip and how to irrigate. And when we talk about Irrisept, this is a wound irrigation company. They're not going to give you any recommendation as to whether you should put this on a hydrophilic surface. They will not. So we have in vitro data which have demonstrated the utility of CHG. And these are two studies that Dr. Cartman has helped to produce. And we thankfully know that Irrisept is biocompatible with the hydrophilic surface. That's good. And also the dipping study that he's performed. In this study, it was evaluating whether a dipped implant in CHG exposed to bacteria and then irrigated, and it would look at the bacterial counts. This is very different than the protocol that we studied in our lab. In our lab, we actually wanted to see and study what remained on the surface of the hydrophilic coating after dipping and irrigating. What was going to happen after you dipped and irrigate? What would happen once you put this into the patient, for example? So that's why we wanted to study what was happening 48 hours after the dipping and the irrigating, because that's where we get the bang for the buck clinically from these devices. When we did that study, we found that irrigating and dipping with vancomycin and gentamicin reduced in a 5-log decrease in bacterial counts. Number two, when we looked at CHG dip as well as CHG irrigation, we had near complete loss of antimicrobial efficacy. Number three, any CHG or any normal saline irrigation also resulted in near complete loss of antimicrobial activity. So this helps me, at least in my clinical practice, to know that I need to be diligent about irrigating. At the end of the case, if I run out of antibiotics, I'm no longer just grabbing that normal saline and taking a little bit of that blood off the pump. I'm going to insist that I continue to use antibiotic solution, for example. We don't know exactly why CHG or normal saline irrigation takes away the antimicrobial efficacy of the hydrophilic coating that has been previously dipped. It could be concentration gradients, it could be competitive binding, van der Waals forces, ionic charges, size of the solution. If you ask me to study this, this is an entire PhD thesis. This is not just some simple thing that we look in the lab and do a few studies. This is really detailed, intense work. However, the main question is, do we actually even care to know? And I would say the answer is no, because now we have clinical data demonstrating that we don't really need to know why. So when we look at the Mayo Clinic experience, which has already been demonstrated, 1,697 cases, there was an increased infection rate, 3.4 to 0% when CHG was used compared to antibiotics. And in the primary cases, as well as in the revision cases, there was increased risk for infection. On Monday, the multi-institutional CHG experience will be presented. This is the updated data that's demonstrated in this slide. It includes 2,933 cases across 14 centers. It includes 2,157 cases utilizing the hydrophilic coating. 50% of these cases were treated with antibiotics. 50% of the cases were roughly treated with CHG. The overall infection rate was 5.1% with CHG compared to 2.1% with antibiotics. And this also was confirmed on the multivariate analysis. This was also confirmed on the subset analysis, which confirmed that CHG, as both in irrigation and dip, continued to increase the risk for infection. Yes, we have a preliminary results, and we look forward to seeing the full results from this two-center prospective randomized non-inferiority study. But when you look at this study, yes, they did not have any overall difference in infection, but let's just look at the subgroups. Here we're looking at the hydrophilic coating. We have a total of 43 patients in this study. And there was one infection in the CHG group, and this was in a patient who had a hydrophilic coated IPP with no additional risk factors for infection. So we look forward to see the data to continue to see what the study shows. Many of you in the audience may say, well, great, he's talked a lot about the hydrophilic coating. What about antibiotic impregnated surfaces? Well, we've demonstrated in vitro that CHG does not take away the antimicrobial efficacy of the antibiotic impregnated surface, and that was also demonstrated in the large 12-center study as well. So my conclusions about CHG are, number one, that the CHG dip in irrigation of a hydrophilic IPP surface results in loss of antimicrobial activity and increases the risk for infection compared to antibiotic solutions. Number two, that CHG irrigation of an antibiotic impregnated IPP surface does not alter the elution of the antibiotics, nor does it increase the risk for clinical infection. So I think in terms of the hydrophilic coating, CHG is too good to be true. There are many benefits, but they're just not worth the risk for infection. And I'd like to leave one last slide, and this is a tale of experience. Experience is another solution that exists, and some have utilized this with prosthetic surgery. It is a solution which is almost like a surfactant or like a soap. Well, we utilized experience in vitro, and we put it on hydrophilic coated implants and tested it against E. coli, and experience did not reduce bacterial adhesion to the hydrophilic implant surfaces. Well, what happened is that we also utilized experience with the antibiotic impregnated devices and tested it against E. coli, and we actually saw that there was increased bacterial adhesion to the surfaces. So I'd like to leave you with my final considerations, and that's number one, that penile prostheses are uniquely coated and impregnated surfaces, and therefore they require different irrigation recommendations than what other medical devices and wounds receive. Number two, there is a real concern about the compatibility of CHG and the hydrophilic surface based on both in vitro as well as in vivo data. CHG is compatible with the antibiotic impregnated surface based on both in vitro and in vivo data. And please be cautious when trying new solutions because they may not be compatible with both the hydrophilic surface and the impregnated surface, just like we saw in the in vitro data with experience. And last, why put patients at further risk for infection? Ask yourself, why not just use antibiotics which are tried and true? Thank you.